Chest pain is one of the most common complaints in emergency medicine, but the way you learn it in textbooks is very different from how you deal with it in real life. Let's see why. In textbooks, chest pain almost always starts with myocardial infarction in bold letters. Then you get pages on incidents, demographics, risk factors, causes, anatomy, and symptoms, followed by tests, treatment, prognosis, and complications, enough to make anyone anxious. All that information can be overwhelming. As a medical student, it scared me too, reading that MI is the #1 killer, millions of deaths, hundreds of millions of cases. Naturally, I started to panic. I remember my first night on call in the UK as a junior doctor. A patient with chest pain came in, and I was convinced he was a ticking time bomb. I quickly referred him to the registrar, who was completely calm. He told me, "I used to be scared of chest pains, but now I just discharge them." That really stuck with me. Here's what textbooks don't mention. About 90% of chest pain cases in the ER are not myocardial infarctions. Most are actually harmless or caused by other conditions. So don't let the statistics scare you. Let's compare the textbook approach and real life, side by side. Textbook: incidents, demographics, risk factors, pathophysiology, and so on. Real life: symptom, test, medication, diagnosis, then either refer, admit, or discharge. It's much simpler. A patient doesn't walk in and announce, "Good evening, doctor. I have a myocardial infarction. Let's discuss incidence rates." They say, "Doctor, I have chest pain. Please help." That's where your focus should be. So, what do? First, manage the pain. Second, check vital signs, usually normal. Third, do an ECG and look for ST elevation. Just focus on STEMI, not every rare syndrome. If there's no STEMI, order bloods: troponin for MI, D-dimer for PE, and infection markers for pneumonia. Do a chest X-ray to rule out pneumonia or pneumothorax. If troponin is raised, you have a diagnosis of MI. If not, repeat the test after a couple of hours. If it's still negative, discharge the patient and arrange chest pain clinic follow-up. If there's STEMI on ECG, send the patient straight to PCI. Don't wait for bloods. For severe chest pain radiating to the back, always consider aortic dissection and check blood pressure in both arms. If suspicious, order a CT angio. Keep medication simple. Start with basic analgesia: cocodamol or Oromorph in the UK, algopyrin or paracetamol in Hungary. Reserve nitrates or morphine for really severe pain. You don't need to overcomplicate it. Here are your key takeaways. Most chest pain is not an MI. Be systematic, not scared. Manage pain, check ECG, bloods, and chest X-rays. Refer STEMIs immediately for PCI. Keep it simple, stay calm, and don't let textbooks make you panic. You've got this. Real-life medicine is simpler than textbooks make it out to be. Stay confident, focus on what matters, and be the doctor your patients need.